There are two kinds of sympathoplegic drugs that are used in the treatment of hypertension. The one that acts centrally, these are the drugs that acts in the brain and they inhibit the outflow of sympathetic nervous system, whereas the other class, it belongs to the group that acts peripherally on the receptors on the organs, and they produce an sympatholytic effect. The drugs that are most commonly used in practice are the drugs that act peripherally in the receptors and produce the sympatholytic drugs, whereas the centrally acting drugs, they have specific applications. We'll discuss the centrally acting first, and in the centrally acting, we have methyl-dopa, clonidine, gabapentin, gabanadrel, and reserpine. We'll start from the methyl-dopa. It is a precursor of L-dopa. L-dopa is a naturally occurring compound that is present in the central nervous system and is a precursor of norepinephrine. This L-dopa, it is an analog of L-dopa, so this is converted into alpha-methyl dopamine in the brain. This alpha-methyl dopamine is converted into alpha-methyl norepinephrine. Now this methyl norepinephrine, it will interact with the alpha-2 receptors in the brain, and it will prevent or it will inhibit the outflow of sympathetic nervous system. That means that there will be decrease in the norepinephrine and epinephrine in the body, and this is how the antihypertensive effect or action appears to be stimulated. This drug was widely used in the past, but now it is primarily used for the hypertension during pregnancy. Methyl-dopa does not cause orthostatic hypotension, which is very common with the other centrally acting sympathoplegic drugs, and this is a very favorable phenomena that is seen with methyl-dopa. It is readily entered into the brain and is converted into its active metabolite, which is alpha-methyl norepinephrine. And the maximal antihypertensive effect of methyl-dopa, it occurs after 4 to 6 hours, that you will give the drug, and after 4 to 6 hours the maximum antihypertensive effect of the drug can be seen. This effect lasts for approximately 24 hours, and because the effect, it depends on the accumulation and storage of this metabolite in the vesicles of nerve endings, the action, it persists after the parent drug has been disappeared from the circulation. L-dopa is a very excellent drug for the treatment of hypertension. However, it has a very long toxicity or side effect profile, and all these adverse effects or side effects, they are mediated centrally. The most common side effect that is seen with methyl-dopa is sedation. That the patients who are taking methyl-dopa, they will experience a sedation. There is lassitude, which is a feeling of unwellness. There is an impaired mental concentration, and because of all these kind of side effects, this drug is no longer used regularly for the treatment of hypertension. Nightmares are very common with the use of methyl-dopa. Depression is very common. So there is also lactation, which is associated with an increased production of the prolactin. And this adverse effect of increased prolactin, it is seen in both males and females. Hemolytic anemia, hepatitis, and drug fever, they can also happen, but these drug effects are very rare, and discontinuation of the drug usually results in the prompt reversal of all these abnormalities. And because of this very long adverse effect profile, methyl-dopa is no longer used for the treatment of hypertension, except in the situation of pregnancy, where it is safe drug or safer drug option as compared to the rest of the drugs. The second drug that comes under the category of centrally acting antihypertensives is clonidine. Clonidine also acts on the alpha 2 receptors in the brain, and produces its antihypertensive effect by inhibiting the outflow of sympathetic discharge by the agonist effect with the at the alpha 2 receptors. The blood pressure lowering, it occurs with the reduction of cardiac output because there is a decreased heart rate and the relaxation of the capacious vessels. So the peripheral vascular resistance is also decreased. Reduction in the blood pressure is accompanied by decreased renal vascular resistance and maintenance of renal blood flow. So this is a favorable thing in the profile of clonidine. It rarely causes postural hypertension. However, the pressor effects of clonidine, when we give the clonidine, the initial effect is hypertension, but after that there is a prolonged hypertension. So the pressor effect, it is due to direct stimulation of the alpha renoceptors in the arterioles, because it is given in the infusion form. As far as the pharmacokinetics is discussed, the clonidine, it is a lipid soluble drug. It readily enters the brain and produces its antihypertensive effect. It has a short half life and it has to be given twice a day. Transdermal patch of clonidine is also available that reduces the blood pressure for 7 days. That you apply the patch and then you're good to go for around 7 days. However, the toxicity profile of clonidine is also similar and a very long as the methyl-dopa. Dry mouth and sedation are very common, and both these effects are centrally mediated and dose dependent. Depression is also very common with the use of clonidine. The tricyclic antidepressants, they block the antidepressant antihypertensive effect of clonidine. Therefore, they should not be given concomitantly. And other very important issue that needs to be addressed with the use of clonidine is the withdrawal symptoms. The withdrawal of clonidine after protracted use, it is associated with life-threatening hypertensive crisis that is mediated by an increased sympathetic nervous system. The patients, they may exhibit nervousness, tachycardia, headache, and sweating after omitting one or two doses of the drugs. Because of the severe risk of the severe hypertensive crisis when clonidine is suddenly withdrawn, all patients who take clonidine should be warned of this possibility. And if the drug, it must be stopped, it should be done gradually while other antihypertensive agents are being substituted. And the treatment of hypertensive crisis is the administration of alpha and beta blockers. So the a very long list of side effect profile renders this to be not to be used as a regular drug as antihypertensive. The next drug in this class are ganglionic blockers. This class contains two drugs. One is hexamethonium and the other is trimethophan. These both of these drugs, they were the first agents that were used for the treatment of hypertension, but they are no longer available because of the intolerable toxicities. They what they do is they directly block the nicotinic acetylcholine channel. The adverse effects are of these are the direct extensions of their pharmacological effect, and they cause sympathoplegia and parasympathoplegia. When there is sympathoplegia, there is excessive orthostatic hypertension and there is sexual dysfunction. And when there is parasympathoplegia, there is dry mouth and urinary retention, the precipitation of glaucoma, blurred vision, and dry mouth. All these fear toxicities are the major reason for the abandonment of ganglionic blockers for the treatment of hypertension. The next class is post-ganglionic nerve terminal blockers, and to understand the mechanism of action of these drugs, you'll have to see this figure. You can see this is a nerve terminal. This is the junction of the nerve terminal, and this is the cell body, and these are the receptors, adrenoceptors. Now we can see that this is a norepinephrine, which is a major which is a catecholamine that is the mediator of the adrenoceptors, and the synthesis of norepinephrine, it initiates from here. Here we have tyrosine. This is an amino acid and it is a precursor of the norepinephrine. It goes inside the cell, converted into tyrosine, into dopa, and then dopamine. And this dopamine goes inside the vesicle. This vesicle, it fuses with the cell membrane or membrane of this nerve terminal, and then it is released in the nerve junction to interact with the renoceptors. However, the drugs gavanitidine, they adrenergic neuron blocking agents, these drugs, they do not let this vesicle they do not let the vesicle fuse with the membrane, and this is how they prevent the release of norepinephrine into the junction. And when it is not released into the junction, there is no activation of the receptors, and this is how the antihypertensive effect is mediated. The next drug, which is reserpine, you can see that what it does is that it prevents the entry of norepinephrine into the vesicle. So either we are trying to prevent the norepinephrine to be released into the junction, and this is how there is no transmitter available to interact with the renoceptors, and the antihypertensive effect is mediated by this mechanism. So the guanidine and gavanadrol, these are the postganglionic nerve terminal blockers. They can produce profound sympathoplegia, and the resulting high maximal efficacy of this drug, it was made it the mainstay of outpatient therapy of the severe hypertension for many years. However, because of the toxicities that are reported with Zamanitine, this drug is no longer used. The most common adverse effects that were seen with these drugs were hypotension, and it was associated with the posture, diarrhea, and impaired ejaculation. These are some other adverse effects of these drugs, and they have a very long half life. The Gavanitidine, it has a half life of around 5 days, and the drug effect, it persists even after the cessation of therapy. So this is not a very desirable effect when we're treating the drugs, and because of these toxicities, these drugs are not longer used for the treatment of hypertension. The reserpine, it is an alkaloid that is extracted from the root of an Indian plant which is called as Revolvia serpentina, and it was one of the first effective drugs that were used on a large scale in the treatment of hypertension, and now it is rarely used because of its adverse effect. We have already discussed the mechanism of action, and the toxicity that is produced with the reserpine is that it produces postural hypertension, and all the other side effects are usually central or related to the GIT. In the central, reserpine causes sedation, it causes lassitude, nightmares, severe mental depression, and even in the patients who are receiving very low doses of the drugs, it may also cause Parkinson disease and extrapyramidal effects. And mental depression is a very common side effect with reserpine. So the patients who already have this issue, they should never receive reserpine because it is going to aggravate the condition of the patient. It also produces mild diarrhea and gastrointestinal cramps, increases the gastric acid secretion, and this drug, it should not never be given to the patients which have a history of peptic ulcer.